Rumination disorder represents one of the most misunderstood and underdiagnosed feeding and eating disorders in contemporary medical practice. This condition, characterized by the repeated regurgitation and rechewing of food, affects individuals across various age groups but is most commonly observed in infants, young children, and individuals with intellectual disabilities. The disorder derives its name from the Latin word ruminare, which means to chew over, reflecting the repetitive nature of the regurgitation process that defines this condition. The clinical presentation of rumination disorder involves the voluntary or involuntary bringing up of previously swallowed food into the mouth, followed by rechewing, reswallowing, or spitting out the regurgitated material. This behavior typically occurs within 30 minutes of eating and continues for a period of at least 1 month to meet diagnostic criteria. Unlike typical infant reflux or gastroesophageal reflux disease, rumination disorder involves a deliberate muscular action that brings food back into the mouth, often accompanied by specific positioning behaviors such as arching the back, straining, or making sucking movements with the tongue. The etiology of rumination disorder remains complex and multifaceted, involving both biological and psychosocial factors. In infants, the condition often emerges during the first year of life, particularly between 3 to 12 months of age. Research suggests that inadequate caregiver-infant bonding, lack of stimulation, neglect, or stressful family environments may contribute to the development of rumination disorder in very young children. The behavior may initially serve as a form of self-soothing or stimulation-seeking activity, particularly in environments where infants receive insufficient attention or interaction from caregivers. Among older children and adolescents, rumination disorder may develop as a response to stress, trauma, or significant life changes. Some individuals report that the regurgitation process provides a pleasant taste sensation or serves as a coping mechanism for managing anxiety or emotional distress. In individuals with intellectual disabilities or autism spectrum disorders, rumination disorder may represent a form of self-stimulatory behavior or may be related to difficulties with communication and expressing needs or discomfort. The physiological mechanism underlying rumination disorder involves the relaxation of the lower esophageal sphincter and the voluntary contraction of abdominal muscles to create pressure that forces stomach contents back up through the esophagus. This process differs significantly from vomiting, as it typically does not involve the nausea, retching, or involuntary muscular contractions associated with emesis. Individuals with rumination disorder often appear to derive satisfaction or pleasure from the regurgitation process, which distinguishes it from other gastrointestinal conditions. Diagnosis of rumination disorder requires careful clinical assessment and the exclusion of other medical conditions that might cause similar symptoms. Healthcare providers must rule out gastroesophageal reflux disease, pyloric stenosis, food allergies, infections, or other gastrointestinal disorders that could explain the regurgitation. The diagnostic process typically involves detailed medical history taking, physical examination, and sometimes additional tests such as upper gastrointestinal studies or pH monitoring to exclude organic causes. The impact of rumination disorder on affected individuals and their families can be substantial. From a medical perspective, chronic regurgitation can lead to serious complications including malnutrition, failure to thrive, weight loss, electrolyte imbalances, and dental problems due to repeated exposure to stomach acid. The acidic nature of regurgitated material can cause tooth enamel erosion, dental caries, and halitosis. In severe cases, aspiration of regurgitated material may lead to respiratory complications, such as pneumonia or other lung infections. Beyond the physical health consequences, rumination disorder can significantly impact social and emotional development. Children with this condition may experience social isolation due to the unpleasant odor associated with frequent regurgitation, leading to difficulties forming peer relationships and participating in normal social activities. Family dynamics may also be affected, as parents and caregivers often experience frustration, embarrassment, and concern about their child's behavior and health. Treatment approaches for rumination disorder typically involve multidisciplinary interventions that address both the behavioral and medical aspects of the condition. Behavioral interventions form the cornerstone of treatment, with techniques such as habit reversal, diaphragmatic breathing exercises, and differential reinforcement proving effective in many cases. These approaches focus on teaching individuals alternative behaviors and helping them develop awareness of the physical sensations that precede regurgitation episodes. For infants and young children, treatment often emphasizes improving the caregiver-child relationship through enhanced interaction, increased attention during feeding times, and creating more stimulating environments. Parent education and support play crucial roles in successful treatment outcomes, as caregivers learn to recognize triggers and implement appropriate interventions consistently. Occupational therapy may be beneficial for individuals who engage in rumination behavior as a form of sensory seeking, helping them identify and access appropriate sensory alternatives. Speech and language therapy might be indicated for individuals with communication difficulties, particularly those with intellectual disabilities who may use rumination as a means of expressing needs or seeking attention. In some cases, medical interventions may be necessary to address complications or underlying factors contributing to the disorder. Proton pump inhibitors or other acid-reducing medications might be prescribed to minimize damage from stomach acid exposure, while nutritional supplementation may be required to address deficiencies resulting from poor food retention. The prognosis for rumination disorder varies significantly depending on several factors, including age of onset, underlying intellectual functioning, presence of other developmental disorders, and access to appropriate treatment. In typically developing infants, the condition often resolves spontaneously or with minimal intervention as the child matures and develops more sophisticated coping mechanisms. However, in individuals with intellectual disabilities or autism spectrum disorders, rumination disorder may persist into adulthood without appropriate intervention. Early identification and treatment are crucial for optimal outcomes, as prolonged rumination behavior can lead to more severe medical complications and ingrained behavioral patterns that become increasingly difficult to modify. Healthcare providers, educators, and caregivers must maintain awareness of this condition to ensure prompt recognition and referral for appropriate treatment. Research into rumination disorder continues to evolve, with ongoing studies examining neurobiological factors, genetic predisposition, and innovative treatment approaches. Understanding the complex interplay between biological vulnerabilities, environmental factors, and behavioral patterns remains essential for developing more effective interventions and improving outcomes for affected individuals and their families. The importance of comprehensive assessment, individualized treatment planning, and ongoing support cannot be overstated in managing rumination disorder effectively. By addressing both the immediate behavioral symptoms and underlying contributing factors, healthcare providers can help individuals overcome this challenging condition and achieve improved quality of life, better physical health, and enhanced social functioning.